Bon dia, everybody. It's my honor to be here today to speak with you at this amazing event. It's also my pleasure, and I have to say my pleasure was enhanced when we were welcomed in this morning by the theme music from Game of Thrones, which is my favorite TV program. I wonder what message is being given there, because as anybody who watches Game of Thrones knows, what happens is everybody pretends to be cooperating and getting along fine, and then they stab each other in the back all the time. Is that what the EAHM is like? It's opening a new view on your organization for me. As you heard, I'm from the OECD, the Organization for Economic Cooperation and Development, and I'm sure not all of you know what the OECD does. So let me try and give you a flavor of what my job involves. Our job is to try and help countries learn from each other's successes, but also mistakes. So, for example, imagine the scenario that one morning some health minister wakes up and says, I've had this brilliant idea that we're spending far too much on salaries, so I'm going to halve the salaries of all hospital managers in my country. What will then happen is that somebody from the ministry will get in touch with us and say, what's the evidence on what the impact of that might be? And I'll first of all congratulate the country on having a modern-day Einstein as their health minister with such brilliant ideas, but then suggest that they should look at the experience of some other country which tried slashing salaries of hospital managers, and the result was that they all resigned. You ended up with a less good set of people as hospital managers, and the result was a disaster. That's my job, to try and collect that evidence on experience across countries so we can do comparisons. And to do that, we collect huge amounts of data. So a lot of the data that I know you're involved in collecting, hospital coding, the data on finance of health systems, all those details end up eventually in our offices at the OECD, so we can standardize them and we can make comparisons across countries. What I'm talking about today, people-centered care. Why am I talking about that? Well, I think this story really is that since the 2008 crisis, in Europe especially, we've had a series of reforms. But those reforms have been essentially reactive in the healthcare sector, trying to put the system back on some sort of temporary equilibrium. I think what we're now seeing is a shift. When we speak to ministers, ministries, we look at the reforms that are in the pipeline in many countries, of a new way of reforming health systems. And the common element is people-centered care and using that as a way of getting more value out of the health system. So in my talk today, which may or may not come up, who knows whether the slides will come up, it doesn't matter. I'm going to do three things. I'm going to talk, first of all, a little bit about the pressures that health systems are under more generally. I'm then going to talk about some of the evidence about why our health systems are failing to meet those challenges. And the third element, we'll be talking about elements of people-centered health systems. I suspect I don't really need to tell you that health systems across Europe and beyond are facing similar and intense challenges. You know this in your day-to-day lives. We've got greater inequalities in our societies, which are feeding through to greater inequalities in health outcomes and health needs. We have that demographic and epidemiological transition that we're still coping with, and indeed is accelerating over the next few years in most European countries. And of course, we have the financial problems. This is where it'd be great if I could show a slide, and I'm still not managing. But let me try and summarize where we were. Before 2008, before the financial crisis, roughly speaking, health spending in Europe was growing at between 4% and 6% per year in real terms, whilst GDP was going up at around about 2% per year. So there was a bigger share of national income going into health systems each year. We then had the crisis. Since the crisis, health spending has been going up on average in Europe by about 2% per year, the same as since the crisis that our GDP is going up. And as you all know, it's not enough. It's putting great strains on our health systems. The slides are appearing there, if not on the back. Yeah, they're there, but they're not behind, so we can see them. I'll talk to you. Okay. I'll talk to you. Okay. You know, as you can see. Hi! There we go. You're free. I can talk to everybody after all. That's the slide of health spending. It's not enough, and that's why our health systems are feeling under pressure. The trouble is, it's not going to get easy over time. Now, this is our attempt to estimate what will be the demands on health spending going way ahead to 2060. And I should say immediately, you should never trust an economist, and I'm an economist, who pretends to know what's going to happen in 2060. We don't know what's going to happen in 2 months' time, let alone in 2060. Nevertheless, what we're doing here is just taking forward past trends, the things that we think have driven health spending in the past, and we're taking them forward, things like demographic change and new technologies. And you can see that health spending is projected, public spending on health, to go up significantly, up to 14% by 2060. Now, I don't know whether you believe that or not. I'm not even sure I believe it, and I did the numbers. But the point is that that is going to be a great stress on our public budgets, because we haven't really felt it up to now. I mean, what people I don't think realize, especially in the health sector, is the way that we've financed health, the increase in health spending in the past few decades has not been by increased taxation. What's happened is that our spending in Europe on defense has gone down a lot. Our spending on subsidies for state-owned enterprises has gone down a lot. And it's almost exactly, you add those two things together, equivalent to how much increase that we've spent on health. So we've financed our increased health spending by spending less on tanks and less on coal mines. Trouble is, there's no money left there to cut in defense or in subsidies to coal mines. So future increases in spending on health will mean more taxation. And the problem is, our populations don't vote for more taxes. That's the challenge that we have in the health sector. We could talk for a long time about how we could try and persuade our populations to vote more money for health. It's the wrong way to go. Much better, I think, is to build on the theme of this talk and this session, is to think about how we can actually restructure our health systems in a way that delivers more for the money and actually, therefore, gets more support from the population. And we know we have huge problems with our health systems, hospitals included. The way that we have developed our health systems has not been around the needs of patients. It's been around structures of providers, around hospitals, around primary care providers, even around pharmaceutical companies. And the way that we deliver care has not been integrated. It has been very much about, do we give more money to hospitals? Not do we give more money to the patients who need more help, it's how much more money do we give to hospitals. So it's all about the providers. And that's the way we've constructed our health systems. And as a result, there isn't really any role for patient voice in our health systems. There isn't really any role for value, actually, in our systems. It's all about how much we provide, not what value we deliver. And nor is there even really any incentive to integrate this complex web of providers properly. And we know what the outcomes are. Alexandre already actually mentioned some of this. The results of this lack of integration is a huge amount of waste in our health sector. When we look at the figures on how many people entering a hospital have an adverse event happening to them. We say 10% here. Actually, there's some recent numbers from Norway talking about 14% of people who enter a hospital door have an adverse event happening to them. That's something like 15% or even more percent of hospital spending is dealing with those adverse events. Even just medication errors, there's a study in Australia just out, 4% of hospital spending, 4%, is just due to medication errors being made in hospitals. I could go on, geographic variation. It's not just hospitals. I don't want to just target hospitals. I've got there something about up to 50% of antibiotic prescriptions being inappropriate. It's not necessarily unnecessary. It's inappropriate. That's especially in the primary care sector. Emergency department visits, an absolute incredible waste of money in many places where we're using expensive types of treatment for inappropriate sorts of care. Huge differences in administrative expenditures. Our best estimate in a study that we published last year is that at least €1 in every 5 that we spend on health is waste, in the sense that it either does absolutely no good for any patient, or it actually does harm for the patients. €1 in 5. I know you're going to have a session that will talk about what hospitals in particular can be doing about that in this Congress, and I think that's fantastic that you're addressing this properly. I could go on to other areas, more structural areas that I think we have massive problems in the health system. I'm not going to spend much time on this, but our health workforce is terribly inadapted to moving towards a more people-centered style of healthcare delivery. Already, when we actually look at whether people have the right skills to deliver the services that they should be delivering, actually we do worse in the health sector than we do in the rest of the economy, despite all the efforts that we put into training healthcare professionals, despite all the effort that we do about scope of practice to make sure that people only do what they've been trained for. We actually do worse than equivalent people with equivalent levels of education in other parts of the economy. And I think this is, in many respects, my favorite graph of illustrating why we need to move towards patient-centered care. This sort of graph. What it does, it looks at the volumes of knee replacements that are taking place in different countries. And I've adjusted these for the age. So there's no differences that are caused by different structures of the age in different populations. And what it's showing is that Austria, at the moment, is doing about 4 times as many knee replacements on a per capita basis as Portugal. Or, if you don't like that comparison, it's doing twice as many as France. Now, I don't believe there's that much difference in the needs for knee replacements in these countries. So, one of the countries is either doing too many, or another one's doing too few. And the tragedy for our health systems is that we don't know. The most basic thing, we don't know whether these are actually, the people receiving these treatments or not receiving these treatments are the right people. And I think that's a sign of how far away we are from providing people-centered care. What we do is that if a physician says it's necessary, we provide it. But then we don't follow up on whether that was the right thing to have done for that person. We haven't actually got any metrics to say, yes, this person really needs this knee replacement. And I think that illustrates in itself just how far away we are from having people-centered healthcare, putting the personal needs at the center. And that's why we're delivering poor value of care for our health spend. I'm going to have to go quickly now. I mean, there's so many things I could talk about how we need to change our policies in order to deliver more people-centered, value-based care. 4 areas I should be mentioning. We should be moving from volume-based payments to rewarding value in our care We should be moving from fragmented systems to integrated them, from the doctor knows best to having a much more health literate population, and also changing the way that we measure health systems, from measuring what health systems do to measuring what outcomes health systems deliver. Very quickly on some of those things. I know you're going to discuss them more during this Congress, and I look forward to hearing about what's discussed. But there's been a big change very recently in countries preparing reforms on how we pay for health care. I was with Lisa in the taxi from the airport yesterday, and she was telling me about the French reforms that have just been announced. This is typical of what's going on, to try and come up with new ways to encourage different healthcare providers to integrate, to merge together, to reward quality of care and outcomes, and not just pay for the inputs that go into the system. And there's a lot of that going on in a lot of countries. I don't think we know exactly the best way of doing this yet. In fact, I don't think there even is a best way of paying for health care. I think probably it's going to be one of those things that we need to experiment an awful lot with and try things out and then change them every few years when some of the disadvantages become more obvious. But certainly I think that's an area we're going to see a lot of changes around in the next few years, just looking at the reforms that are being prepared in different countries. Integrating services around people's needs. Of course, we've been talking about that for ages. But there's all sorts of structural reforms that are either being introduced or being considered in countries, things like introducing new care settings in order to get people, for example, out of hospitals much more quickly, even if they're not going to go into long-term care, so to manage the transitions from different systems. The merger of providers, both vertical and horizontal. Making incentives so that different parts of the system work together better and navigating, helping people in particular with complex needs, lots of innovations going on there. And I think there's one way that I will just draw your attention to, which I think just illustrates how backward we are in the health sector in actually doing this sort of integrated system. This is a survey we did fairly recently, about 2 years ago, in fact now, where we looked at the technical readiness of countries to be able to use electronic health record data in order to govern the system better, but also the governance readiness. So actually, do they have the legal and institutional structures in order to be able to use that data? And what we found was there's about 10 countries possibly are in a position that they could actually use all that electronic health data to govern the system better. Now, potentially, this is a source of enormous efficiencies, as you know, in Portugal, just in one particular area. The way that you manage your waiting times system, we often use as an example for other countries to copy from, because it's using data and actually, therefore, getting a more efficient way of managing waiting lists. But only 10 countries. Now, the reason why I'm highlighting that is that that's approximately 15 to 20 years behind where the financial services sector was in using its data to run financial services more efficiently. That's how far behind the health sector is from the financial services. And yes, I know there's different issues, but privacy is an issue for the financial services sector as well. It's also incredibly complex with lots of different parts of the system. So we are way behind being able to actually bring the sources of data that there are together in order to be able to make the bits of the system work together more sensibly. I'm showing a slide on healthcare literacy because often when we talk about value, we do still talk about how we need to change providers, but I think the counterpoint of changing provider behavior is that we also do need to think about how we can get a more health literate population. There are studies from the United States, for example, that suggest poor health literacy accounts for 5% of health spending, and the US spends a lot on health. And that's because people are giving inexact, inappropriate responses when they're asked questions, or they're not following the instructions that they've been given in their treatment protocols. And I think this is something that when we talk about value-based care in our health systems, we need to take more seriously. And again, what we're seeing amongst countries is much more interest in this concept of population health literacy as a way of enabling providers to actually move towards a value-based system. But I'm going to spend the last 2 minutes, there's a big clock here that's ticking right in my eye line, so I know I have 2 minutes left, talking about metrics, about the way that we measure the health system. And this is where I have to do a mea culpa. My organization, as I said, we collect huge amounts of data so that we can do comparisons across countries. Nearly all of it that we collect is on process. It is about how much we spend. It's on how many operations we do. It's on things that are done rather than things that are achieved. And that's just not good enough if we want to be delivering a more value-based, people-centered healthcare system. And so last year we had a big meeting of ministers from all the OECD countries, and they gave us a mandate. They requested, they told us, if you like, that what we had to do over the next 5 years is to develop internationally comparable measures of outcomes from the patient point of view. And it's called PARIS, our acronym. It's Patient Reported Indicators Survey. And there's various parts to this. Some of it is taking particular diseases. Many of you will know the ICHOM approach. We work with ICHOM on this, to pick a particular disease, a particular intervention, and develop patient-reported outcome measures and patient-reported experience measures so we can see what the outcomes of these interventions actually are for the patients. But in addition, we'll be doing some work on people with more complex needs, with multimorbidities in the primary care sector, so that we can identify the outcomes of people in the primary care sector and how well our health systems are reporting there. And the sorts of questions we will be getting answers to are, to what extent are people in pain after hip surgery? What's the quality of life for people with cancer treatments? Can people live independently after strokes? These are the things that matter to people. Not did they have a hip replacement, but whether it's actually improved their quality of life. Can they live independently after they've finished their treatment? And yeah, this is one of my favorite charts. I know I'm slightly over time, but I'm going to show it anyway. Just as an example of the insights that we can get from this. This is German data. It's looking at the 5-year survival rate for people with prostate cancer, and it compares in pink the average performance and in blue the best performance. And you can see there's virtually no difference between survival rates between the best and the average in Germany. But when you look at other things that really matter to patients, there are enormous differences. Your chances of getting an erection after surgery, your chances of being incontinent vary enormously across different providers. And this is what we mean by people-centered care. Because unless we take these things that matter so much to people seriously, then we're not really providing value and the healthcare we want. Similarly, when we actually ask people what's their experience of healthcare, we get these big differences in countries. I mean, I think anybody who's experienced the Japanese health system won't be too surprised to find them bottom of the list. It really isn't very pleasant. Poland not doing at all well there. Belgium being the best performer in terms of doctors spending time and indeed in other metrics like listening to what patients want. So those are the sorts of things that we will be measuring and making comparisons of in the future. And I hope that will support you as you move towards a more people-centered, value-based health system. And I just want to therefore conclude by emphasizing, the demand for people health systems. It's really not just coming from the need to be more efficient. I think having a more people-centered, value-based system will make our health systems more efficient. But there's a bigger picture here that we won't just be able to pump more money into our health systems in the future. We need a different way of being able to sell what our health systems are doing to the population, and I believe that must be people-centered. Many, many ways in which our health systems must change to achieve that goal. I hope I've given you some insights into what they might be today. So good luck with your conference, and thank you very much.